Thank you for inviting me to participate. So these are my disclosures. So the goals and objectives of this talk are shown on this slide. I'm going to review briefly the epidemiology, genetics, and diagnosis of ADPKD. I'm going to review clinical issues and management at different stages of the disease. I'm going to describe the utility of total kidney volume as a marker of disease progression. And I'm going to discuss current and new potentially disease-modifying therapies. So as Dr. Hildebrand just described, ADPKD is a dominant dominant genetic disorder. It's a systemic disorder associated with bilateral kidney cysts with progressive decline in GFR leading to kidney failure in about 50% of patients by the sixth decade. In addition, there are extrarenal manifestations, cysts and extracellular matrix abnormalities. Cysts primarily affect the liver, and extracellular matrix abnormalities can lead to cardiac valvular defects or intracranial aneurysms. And if that weren't enough, all of the issues associated with chronic kidney disease, including anemia, metabolic bone disease, nutritional disorders, and increased cardiovascular risk. ADPKD is a relatively straightforward diagnosis by imaging when it's in its obvious form. These are a series of MRI images. On your left are the T2 weighted images, and in these images, the cysts are white and parenchyma is dark. On the right side is the T1 window, and in this case, cysts are black. And these patients were administered gadolinium, so the parenchyma is white. We don't administer gadolinium anymore for routine imaging in ADPKD. And this is 4 different patients, but it illustrates the progression that occurs with increased numbers and size of cysts in both kidneys, increased size of the kidneys, and eventually most of the kidney is taken over by these large cysts. ADPKD is a common kidney disease. It's the most common hereditary kidney disease affecting between 1 in 1,000 and 1 in 2,500 individuals. It accounts for about 8 to 10% of patients on dialysis with direct medical costs that easily exceed $1.5 billion a year. In addition, there's substantial indirect costs, which include pain and suffering, unemployment, and family disruption due to multiple generations, possibly requiring transplant or dialysis. The genetics are fairly well known. It's inherited in an autosomal dominant fashion. There are 2 known genetic loci. Most individuals inherit PKD1, which has been localized to chromosome 16. PKD1 encodes a protein called polycystin 1. About 15% of individuals inherit the disease due to PKD2, which encodes a protein called polycystin 2. And the diseases are phenotypically identical, except PKD2 results in a milder disease with later age of diagnosis, later onset of hypertension, smaller kidneys, smaller numbers of cysts, and later age of ESRD. This is a large pedigree which illustrates the burden of ADPKD spread through multiple generations. So this arrow here represents our proband, and this individual has affected siblings, an affected parent, affected aunts and uncles over here, affected grandparent. We don't know yet if this individual's children are affected, and if these children also have cousin. Well, this is a cousin, and this would be nieces and nephews the individual has. So this is a very devastating disease that impacts multiple members of the family. And again, half of them result in kidney failure or a need for dialysis or transplant. The progressive loss of kidney function is different between PKD1 and PKD2. These are kidney survival curves. This represents loss of kidney function necessitating dialysis or transplant. And the median age of end-stage renal disease is 54 for PKD1 and 74 for PKD2. So definitely a slower disease, but nonetheless, one doesn't escape the ravages. Ultrasound criteria for diagnosis of ADPKD in a PKD1 family are well established. So if an individual is less than 30 years of age, at least 2 cysts in either or both kidneys confers a greater than 95% sensitivity and specificity of having PKD. Because you get more simple cysts as you age, you need more cysts to demonstrate with high degree of certainty PKD when you're older, so at least 2 cysts per kidney, ages 30 to 59. And when you're greater than 60, you need at least 4 cysts per kidney. Now, we don't usually genotype people, so we don't know if people have PKD1 or PKD2. But you can make a pretty good guess is that if there's at least one first-degree family member with end-stage renal disease less than the age of 55, that's very likely due to PKD1. Now, as I said, we don't know the genotype because we don't genotype most individuals. And the modified Ravine criteria published now about 10 years ago by York Pei and his coworkers have expanded the definitions of numbers of cysts per age. So you'll notice we go from 15 to 39, and you need at least 3 cysts in either or both kidneys. Ages 40 to 59, at least 2 cysts per kidney. And ages greater than 60, at least 4 cysts per kidney. And there's no disease if you're older, 40 or older, and you have less than 2 cysts. So what's new in PKD genetics? I'm going to talk about protein truncating versus non-truncating PKD1 mutations when there's absence of a positive family history and an ADPKD-like phenotype. So what are protein truncating and protein non-truncating mutations? A protein truncating mutation is one where the mutation occurs and prevents the RNA from being transcribed, and there's no protein produced. And these are the most severe mutations. And you can see, if you look at renal survival, the blue line here represents a protein truncating mutation with a much faster decline in kidney function than those in the green line, in which the protein is non-truncated and there still remains some activity. PKD2, as I showed you earlier, has a less severe course, and those with no mutation detected who may not have classic PKD mutations have the best prognosis. So the type of mutation has a definite impact on the prognosis. What do we know about when there's absence of a family history of ADPKD? There could be a de novo mutation, that is one that occurred from an egg or sperm that was produced by a parent, resulting in a mutation that first appears in the embryo. A somatic mutation occurs after the embryo is formed, when the multicell embryo is dividing, and a mutation occurs in one of those cells, and then all of the subsequent progeny of that mutated cell will exhibit the PKD gene. And so this may result in unilateral disease or asymmetric disease, again, in the absence of a family history. There are newly described PKD genes that I'll talk about. It's also possible that there would be very mild disease in a parent, which was previously undetected. Sometimes parents are diagnosed after their child is diagnosed. And of course, inaccessibility of medical records. Someone has died. They're raised in a different country, so you don't really know the history. I'll talk about the ADPKD-like phenotype. There are 2 genes which result in this, GANAB and DNA JB11. These are relatively uncommon. So in GANAB, and I'll show you more examples of this, there's bilateral kidney cysts with generally preserved kidney function and very variable polycystic liver disease. Can be very mild or can be severe. DNA JB11 is associated with normal or small-sized kidneys with multiple cysts, a slow evolution to end-stage kidney disease, and absent to moderate polycystic liver disease. This is a slide of several kidneys in an individual with the GANAB mutation, which is related to the glucosidase 2 subunit alpha. And this is a CAT scan. And again, you see these funny-looking kidneys, a lot of normal parenchyma, and a few large cysts. And in the left kidney, you see a very large cyst, and there's a few small cysts in the liver in this individual. And this is just a different section of the same patient, showing more liver cysts and very large cysts in the right kidney. This is an MRI in another individual. And again, mostly normal parenchyma with large cysts in the middle of the right kidney and the left kidney, and a few cysts in the liver. So these are, I call them funny looking kidneys, and they give you clues as to that may not be typical ADPKD. Well, the kidney manifestations of ADPKD are all due to increasing total kidney volume. And total kidney volume is due to cysts scattered throughout both kidneys. And the increase is typically inexorable, and it's associated with acute and chronic pain, palpable kidneys, progressive loss of kidney function, hypertension, intermittent hematuria, cyst infection, pyelonephritis, nephrolithiasis, and impaired concentrating ability. So with work done with the PKD Outcomes Consortium and Critical Path Institute, we were able to convince the FDA and the European Medicines Agency, showing quite detailed data, that total kidney volume was associated with progressive loss of kidney function. And as a result, both FDA and EMA, they released a guidance for industry that qualified the biomarker total kidney volume as a prognostic biomarker. So when you do clinical trials in ADPKD, you pick patients who have larger kidneys because that's associated with a greater likelihood of progression. Another way, which you're familiar with, I'm sure, is the Mayo imaging classification from Maria Razabal and Vince Torres. And this is done in a smaller group of patients, but it illustrates the impact of total kidney volume progression. So this is patient age on the x-axis. This is kidney volume corrected for height on the y-axis. And those people who have faster growing kidneys have larger kidneys at a younger age. So for example, if the individual is 20 years old and you have large kidneys, this indicates that your kidneys grew at a rate greater than 6% per year, and this would be class 1E. Whereas if you're an older individual and your kidneys are smaller, this means that your kidneys are growing at a slower rate, typically less than 1.5% per year, and this indicates a much better prognosis. And these classes translate into these predicted rates of GFR progression. So for example, this is a class 1A, this is a class 1E. This classification only applies to typical ADPKD, that is where you have cysts scattered throughout both kidneys. So let's talk about a few patients. Patient number 1 is a 33-year-old female who's been newly diagnosed without hypertension, relatively preserved GFR. She has a positive family history for ADPKD, where her paternal grandfather died at a young age with hypertension, was not formally diagnosed. Father had ADPKD, developed kidney failure at the age of 51 and had a kidney transplant. And a sister who's a couple years older has ADPKD and hypertension. And her only symptoms have been polyuria and enuresis. And by ultrasound, you can easily see the cysts scattered throughout this kidney. The kidney length is increased. But an MRI done, again, non-contrast MRI, and this is the T2 phase, showing the kidneys are almost twice normal size, multiple cysts scattered throughout the kidneys. This is not a subtle diagnosis, right? This is an easy diagnosis to make by MRI. And we've estimated her kidney volume using the ellipsoid technique, which is the basis of the Mayo classification. So how did we approach management of this individual? Well, I'll talk about all of these in some detail, but blood pressure control, sodium restriction, hydration, maintenance of normal BMI, and lipid control. So based on the HALT study, we target a more aggressive blood pressure target using ACE or ARB for younger individuals ages 18 to 50 with preserved eGFR that is greater than 60, And others, we use a more standard goal of 130/85. And I'll talk about each of these other items in detail. So dietary sodium intake is associated with increased progression. So the CRISP study, which was an observational cohort of about 240 individuals, which helped to generate the Mayo imaging classification, the average daily dietary sodium was 4.3 grams, and increased sodium intake was associated with increased total kidney volume. In the HALT study of about 1,200 individuals, the average daily sodium intake was about 4.1 grams. In study A, where we measured kidney volume with MRI, increased dietary sodium intake was associated with faster increase in total kidney volume and faster decline in eGFR. In study B, where we did not measure kidney volume, increased sodium intake increased the risk of the composite endpoint of 50% decline in eGFR, ESRD, or death. And despite patients being taken care of at major academic medical centers with tremendous experience in ADPKD and patients given counseling, we didn't have much success in lowering their sodium intake. In CRISP, there was no change. In HALT study A and HALT study B, we had somewhat greater success in lowering dietary sodium intake, but not below 3 grams. I'll talk more later on about vasopressin, but we know that vasopressin is associated with faster progression of ADPKD. And our goal in patients should be to reduce urine osmolality below 280 or to decrease urine osmolality by at least 300 from baseline. This requires a substantial intake of water, typically at least 3 liters a day, but sometimes more. And you all recognize that urine output is affected by solute intake. So if you have a large solute intake, that will increase the urine output and will increase the fluid requirement. So solute in our diets consists primarily of salt and protein, and it would be very important both to decrease the urine osmolality and to decrease progression to lower the salt intake as much as possible. And similarly, we tend to eat way too much protein. So that would be another tactic to try and decrease osmolar load and decrease the progression. And in patients who were at risk of hyponatremia, we would not prescribe a large water intake for fear of causing hyponatremia. So in the HALT study, we were able to look at kidney volume growth as a function of weight. And both overweight and obesity were associated with faster total kidney volume growth and eGFR slope decline. And if you look at this figure, it shows the annual percentage change in total kidney volume in normal weight, overweight, or obese individuals. And there's a whole new field of research on metabolism in ADPKD, and we know that mild to moderate caloric restriction in rodent PKD models decreases cystogenesis. So there are many reasons, in addition to cardiovascular health, to maintain a normal body weight and a modest caloric intake. Well, let's go to patient number 2. This is a 45-year-old female. She has hypertension. She's on medication. Her eGFR was 61, so almost CKD3. Family history unknown. Her only symptom was fatigue. And she had fairly large kidneys, almost 4 times normal size. And she ended up being a Mayo class 1C. So again, increased risk of rapid progression. So regarding the renin-angiotensin-aldosterone system in ADPKD, you could think of ADPKD as a model of bilateral or multiple renal vessel arterial stenosis. So bilateral cysts encroach on small arteries. They increase renin, they increase angiotensin II, resulting in increases aldosterone and renal sodium retention, and the direct effect of angiotensin II to increase vascular resistance. Both of these produce hypertension. In addition, In addition, angiotensin II has downstream effects of fibrosis, increasing fibrosis and increasing mitogenesis. So the HALT study, which I can only review briefly, demonstrated that intensive blood pressure control in hypertensive ADPKD patients, again, aged 18 to 50 with eGFR greater than 60, is well tolerated and safe. And this was associated with a 14.2% slower rate of total kidney volume growth over 5 years, reduced left ventricular mass index, urinary albumin excretion, and renovascular resistance, with a borderline benefit on eGFR progression. Secondary analysis revealed a greater benefit in those who were classified as Mayo Class 1D and 1E, where they had slower TKV growth and slower eGFR decline. So there was no benefit of combined ACE-ARB, and I would not use combined ACE-ARB to treat hypertension ADPKD. In those with eGFR below 60, again, the study goal of 130/85, below that is reasonable. The preferred order of treatment would be ACE or ARB, moving to a cardioselective beta blocker, a calcium channel blocker, and a diuretic. We typically avoid diuretics as first-line therapy in ADPKD because their use has been associated with faster progression and a worse renal prognosis. Patient number 3, this is a more advanced case of ADPKD. A 38-year-old male, he has hypertension, he's on therapy, his GFR is reduced. His father had ADPKD with end-stage renal disease at 68. He had a preemptive transplant. He also had an uncle with ADPKD. And he had recurrent gross hematuria and pain and underwent a laparoscopic left nephrectomy at the age of 38. And this is a CT scan with contrast. You can see mostly cyst with few little isolated areas of normal parenchyma. And then down here in the lower pole of the kidney, you see areas of cyst hemorrhage, which led to such severe pain. The kidney was removed, even despite the reduced GFR. And finally, this is a fourth patient, 41-year-old female who did not have hypertension, who had reasonably preserved GFR. And she had an interesting family history. She had a daughter who had liver cysts, a mother with kidney cysts. We don't know if her mother had liver cysts. And she presented with very profound abdominal symptoms and ended up with genetic testing that showed PKD2. So this is the MRI T2 window, and this is all liver. And you can see that the liver is almost entirely taken up by lots of these white cystic blobs. And she had an enlarged liver, and this was the source of her abdominal discomfort. And this is not that patient, but another patient with massive polycystic liver disease, again showing the cysts spread throughout the parenchyma and causing a distended abdomen. So I'll talk briefly about the extrarenal manifestations. So hepatic and pancreatic cysts are the most common cystic extrarenal manifestation of ADPKD. They're asymptomatic in many patients, but they can expand and cause pain, abdominal distension, and infection, typically worse in females, and very rarely massive polycystic liver disease, such as I showed you in the previous slide. And generally, we advise avoiding exogenous estrogens. A very common question I get from young women is whether or not they should take oral contraceptives. And I usually do a screening abdominal imaging study to see if they already have liver cysts. And if they have liver cysts at a young age, I would not use an oral contraceptive. In individuals with more advanced disease, one could consider off-label use of somatostatin. That has its own issues, including the requirement for monthly injections. But some patients have achieved significant symptomatic relief. Cardiac valvular abnormalities, typically associated with prolapse and regurgitation of the mitral, tricuspid, or aortic valve, and non-ischemic cardiomyopathy, which is relatively rare. Brain aneurysms. Risk of rupture depends on size and location. They're found in approximately 5% of patients with no family history of subarachnoid hemorrhage or aneurysm, and about almost a quarter of people who have a family history of such. Typically, we screen those with a positive family history, those with high-risk occupations, and those who request, so that if someone is worried about this sword of Damocles hanging over them, it's not unreasonable to do a study to rule out brain aneurysm. So the study of choice is a non-contrast MRA, different than an MRI. So you don't need contrast. Seminal vesicle cysts are found in 40 to 60% of men. So these occasionally show up in infertility clinics. And there's generally people with PKD are not thought to be infertile, but there are some men perhaps who are infertile, potentially because of a sperm motility issue related to a ciliary defect. So I'm going to talk about assessment of the risk of rapid progression by imaging. This involves the Mayo imaging classification, and those that have faster rates of progression, that is Mayo Class 1C, D, or E. You exclude atypical, that is Mayo Class 2, ADPKD. And in clinical practice, we don't have the opportunity to measure kidney volume using the complicated techniques that have been used in research studies. So we use the ellipsoid formula, and Mayo has placed a calculator online, which I'll show you. And recall that ultrasound is not sufficiently accurate to estimate total kidney volume. So again, this is the Mayo imaging classification that I showed you earlier. 1C, 1D, and 1E represent rates of progression greater than 3% per year. And again, typical ADPKD with cysts scattered throughout both kidneys. So what is atypical ADPKD by imaging? So Mayo 2A refers to basically funny cyst distributions, unilateral, segmental, asymmetric, lopsided, and Mayo Class 2 is associated with atrophy of the kidneys. So these are some examples. I'll show you down in the lower right hand. So this is an example of an atypical presentation, 44-year-old female, well-preserved GFR, entirely normal right kidney except for one cyst. And then the left kidney shows several large kidneys. This woman is at low risk of progression. This is another patient, 65 years old. She has a GFR of 55, so she clearly progressed very slowly. These would be considered lopsided kidneys. Again, not at risk of rapid progression. And this is an older female, 68 years old. GFR is already quite low, and kidneys are small and atrophic. So again, this would not be someone at risk of rapid progression. So you can Google ADPKD classification, and you come up with this web-based algorithm. And the formula for calculating total kidney volume using the ellipsoid technique is shown right over here. You don't actually need the calculator, but it's pi over 6 times length times width times depth from an MRI or a CT image. The calculator is here. You pop in the values, and it comes up with total kidney volume. And then if you enter height and age, it will give you the Mayo, the imaging classification. So this is very useful. You can ask your radiologist to calculate these measurements for you. Again, length, width, and depth. And any DICOM imaging program has the capability where you can do this yourself. And it's really not that hard. Another way to assess risk of rapid progression is to use the PRO-PKD score developed by French investigators from Western France. And this requires understanding of the genetics of the individual family. And this is a point score for a total of 9 points. And so a protein truncating PKD1 mutation gives you 4 points, whereas a PKD2 mutation doesn't give you any points. And if you have events below the age of 35, so hypertension below the age of 35, or urological events below the age of 35, you get 2 points for having each of these. If you're male, you get 1 point. And so high risk is greater than 6 points. I will point out that hypertension below the age of 35 and urological events below the age of 35 are typically associated with enlarged total kidney volume. So this classification isn't completely separate from kidney volume, but they did not measure kidney volumes. As we don't usually genotype individuals in the US, most of us will not use that. I'm now going to talk about vasopressin and vasopressin suppression, and then start talking about tolvaptan. So we know from preclinical work that if you block vasopressin with this drug, OPC 31260, which is mosavaptan, in these 4 different rodent models, there's marked amelioration of cystogenesis compared to the untreated control animals. If you convince the rats in this upper panel to drink a lot of water by putting sugar in the water, in this PCK rat model, you lessen cystogenesis. This only works in rodent models that have distal nephron cysts, where the cysts are affected by the vasopressin receptor. And the most elegant series of experiments is, since we're in New England, we need to talk about Brattleboro, Vermont. Brattleboro rats lack vasopressin. And so if you interbreed Brattleboro rats with rats containing the PKD gene, as is shown here, this kidney is from a rat that has PKD, but no vasopressin. And you can see that cystogenesis is virtually completely eliminated. And then if you take the same animal with PKD, but without vasopressin, and administer vasopressin, the PKD becomes expressed both in male and female rats. So a compelling story for vasopressin. Well, the tolvaptan study was published, the initial study 7 years ago, which is hard to believe. It's Tempo 3-4. And tolvaptan slowed the rate of kidney volume increase by half. So the tolvaptan treated individuals, the kidneys increased at 2.8% per year, whereas in the placebo group, kidney volume increased at 5.5% per year. And this corresponds to the Mayo class advanced C and D. If you look at inverse serum creatinine, again, tolvaptan in blue slowed the rate of deterioration as compared to placebo. Tolvaptan also decreased pain events, as shown here. The blue line indicating tolvaptan, less pain, and fairly quick separation between tolvaptan and placebo. This was highly significant. And tolvaptan also reduced hematuria, stones, and urinary tract infections. This slide shows the open label follow-up of Tempo 3-4 and the Tempo 4-4 study. And the key secondary endpoint was eGFR. And in the long-term follow-up, so this is the tolvaptan treated group. This is the open triangles represent the placebo-treated group. Everyone was taken off medication and then restarted. And you can see that the tolvaptan-treated group maintained their GFR benefit as compared to the delayed tolvaptan-treated group and the initially placebo-treated patients. And this difference just reflects the hemodynamic effect of tolvaptan. So FDA did not approve tolvaptan at that time, and another study was done called Reprise to look at later stage ADPKD. This was in individuals 18 to 55 years of age with a GFR between 25 and 65, and in older individuals 56 to 65 with a GFR between 25 and 44. And this was done to assure that these individuals were at risk of progression. So this is a complicated study design. It's called randomized withdrawal. So after screening and placebo run-in, everybody in the study was giving tolvaptan. And you had to tolerate at least 60-30 or 90-30 for a 3-week period. Once you tolerated that, individuals were randomized. So some people continued on tolvaptan and some people were randomized to placebo. This continued for 12 months, and then everyone was followed up all off drug. And the primary endpoint was the mean of 3 pre-treatment off-drug baseline EGFRs compared to the mean of 3 post-treatment off-drug EGFRs. The secondary endpoint was the slope from placebo run-in to follow-up. And all of these arrows here represent points that were used to calculate the slope. So tolvaptan in the REPRISE trial met its primary endpoint. There was a significant preservation of GFR by 1.27 mLs per minute. This was seen in individuals younger than 55, but not seen in individuals 55 and older. Same in men and women. Not a significant benefit in a non-Caucasian group, but a very wide standard deviation reflecting that some of these individuals had benefited. Further, again, in the CKD2 individuals, small number of individuals, very wide error bars. So some of these individuals must have benefited. Recall that in the REPRISE trial, there was no assessment of total kidney volume. So if you're going to use tolvaptan in CKD2, you need to probably figure out whether or not they're at risk of rapid progression, especially if they have CKD2. So one of the issues associated with tolvaptan is that there were elevations of the ALT in both trials. In the REPRISE trial, it was 5.6% versus 1.2%. In the TEMPO trial, it was 4.4% versus 1.2%. And there were no cases that met Hy's laboratory criteria, which is a marker of more severe liver injury. And we think this is likely due to more frequent hepatic monitoring on a monthly basis. And this is the basis of the risk evaluation and mitigation strategy that's been employed by the FDA. So Vince Torres in Mayo Clinic was involved with tolvaptan from the very beginning and had almost 100 patients that had long-term use of tolvaptan. And he was able to look at the rate of EGFR decline compared to matched controls. And these controls were matched from the CRISP and the HALT subjects from the NIDDK database. And they looked at the stability of EGFR slope of tolvaptan-treated patients over time and the observed versus the predicted GFR at last follow-up. Now, remember, tolvaptan has an initial effect, initial GFR decline, just like an ACE inhibitor. These are the annualized EGFR slopes of individuals on tolvaptan. This is either from baseline to last follow-up or month 1 to last follow-up. These are the slopes, about -2 mLs per minute per year, as compared to the matched controls from the HALT and CRISP studies, declining at about 3.5 mLs per minute per year. In addition, if we look at those individuals who were treated for more than 5 years, there were 36 of them, mean follow-up of 7.7 years. The observed GFR, shown here in the red, is much better by 8.3 mLs per minute than the predicted GFR based on the Mayo imaging classification. So a sustained long-term benefit. This has been translated to estimates that are shown in these 2 graphs in the paper from Chabib et al. And the point is that the earlier you start tolvaptan, whether based on the TEMPO design or the REPRISE design, the greater the theoretical benefit, almost 7 years delay till ESRD. Whereas if you start at a GFR of 30, when GFR has further declined, the benefit is between 1.5 and 2.3 mLs per minute. So these are theoretical, but it illustrates the point that the earlier you start, the more likely you are to have benefit. So what are the indications? This is a screenshot of the FDA label, reminding you that the generic name of GnRQ is tolvaptan. There's no generic manufacturers in the US at this time. Tolvaptan is a selective vasopressin B2 receptor antagonist indicated to slow kidney function decline in adults at risk of rapidly progressing ADPKD. So to initiate tolvaptan, you have to establish the diagnosis of typical ADPKD, establish the risk of rapid progression, Mayo classes 1C, 1D, 1E. We propose a GFR greater than 25 and individuals aged 18 to 55. Exclude those with contraindications related to impaired ability to sense thirst, liver disease, etc. Both you and the patient have to enroll in the risk evaluation and mitigation strategy, monitoring LFTs at baseline, at 2 and 4 weeks, every month for 18 months, and then every 3 months forever. You need to educate the patient, this is very important, about what it's like to tolvaptan, how you manage the polyuria. As I mentioned, the LFT monitoring, typically measure electrolytes in creatinine and uric acid, at least for the first few months. You adjust the water intake for either hyper or hyponatremia. And what I do is adjust the dose based both on tolerability and the pre-dose urine osmolarity. So you want the pre-dose, so the first morning UOSM, you want it to be less than 280. Now, this was not done in the studies. In the studies, there was forced titration based on tolerability. So I find that some patients are tolerating a lower dose, but still achieving efficacy by measuring that pre-dose UOSM. So this, again, is a screenshot from the label, and I'm just going to jump ahead. So you have to sign up for the REMS. You have to report to the REMS on an online portal periodically, and make sure your patients get their LFTs. Tolvaptan is only given on as a 1-month supply. So there's ongoing clinical trials. There's a number of pilot and phase 2 studies shown here: metformin, niacinamide, pioglitazone, curcumin, statins, caloric restriction. Tessivetinib is a SRC kinase inhibitor. Venglustat affects lipid metabolism. Bardoxolone affects fibrosis and inflammation. Lixivaptan is another vasopressin receptor antagonist. Octreotide and lanreotide lower intracellular cyclic AMP, which is integral to cyst expansion. And there's even a trial of high water intake that's being done in Australia. So in summary, this is a very exciting time for ADPKD, both research and clinical care. There's lots of supportive data to support blood pressure, dietary, and lifestyle interventions to improve kidney and cardiovascular outcomes. There is a more precise definition of genetics with impact on diagnosis and disease course. The methods to establish risk of rapid progression have been established. There's one approved agent. There's many others in the pipeline. And thank you very much for your attention.